Today we're going to talk about neck masses in pediatric. I hope our medical student, interns, and resident will find it useful. To start with, we have to talk about neck triangles, the anterior triangle and the lateral triangle. The anterior triangle of the neck is the part that lies between the mandible, the edge of the mandible, the posterior border of the sternomastoid, and the superior border of the manubrium. The lateral neck triangle is the part of the neck that lies lateral to the lateral border of the sternomastoid and above the clavicle. The anterior neck triangle is subclassified into 4 different triangles. The submental triangle that lies between the hyoid bone and the anterior belly of the gastric. The digastric triangle that lies between the 2 belly of the gastric, the posterior and the anterior belly. The carotid triangle between the posterior belly of the gastric and the superior belly of omohyoid muscle. And the muscular triangle surrounded by the borders of the sternomastoid muscle and the superior the border of the superior omohyoid and the midline. The lateral neck triangle, on the other hand, is lateral to the sternomastoid muscle and above the clavicle, and anterior to the trapezius muscle. It's subclassified into the supraclavicular triangle below the omohyoid muscle, posterior belly of omohyoid, and the occipital triangle above the omohyoid, posterior belly of omohyoid. How we classify neck masses? We classify them according to the site into midline neck mass or lateral neck mass, which can be in the anterior triangle or the posterior triangle, or according to the cause, whether congenital or acquired, or the pathophysiology. It can be non-neoplastic, congenital, or inflammatory, or neoplastic, which can be benign or malignant. In the history, it's very important to mention the age of the patient, location of the neck mass in relation to the neck triangles, the duration, drainage or discharge, and whether it's painful or painless. Physical examination, you have to mention the location, the size, tenderness, mobility, movement with swallowing, pulsatile or not, any sinus or cyst or punctum or discharge. It's very important to examine the oral cavity, looking for any ulceration. Make sure you examine underneath the tongue. Examine the larynx by asking the patient to phonate and check the voice. Examine the thyroid, the whole lymph node basin. Examine the skin, the scalp, the back of the neck, the upper chest, and examine the abdomen, looking for any spleno or hepatomegaly. Differential diagnosis of midline neck mass. One of the most common is thyroglossal duct cyst, dermoid cyst, and thyroid swelling. This is an example of a midline neck mass. As you can see, this is the swelling. When the patient extends her neck, usually the midline neck mass can shift a little bit to the lateral side, but overall it's in the midline. This cyst is typical for thyroglossal duct cyst. It's at the level or just below the hyoid bone. When you ask the patient to swallow, you can see the cyst is moving up and down, which is a very classical picture of thyroglossal duct cyst. It's very important to examine the thyroid, make sure the thyroid in a normal location and no thyroid nodule. Ask for ultrasound to make sure the thyroid is normal location and this is not an ectopic thyroid tissue. Again, thyroglossal duct cyst arise from the remnant of the thyroglossal duct, which is the duct that lies between the foramen cecum and the normal location of the thyroid. Its function is to facilitate the migration of the thyroid tissue from the floor of the mouth, the foramen cecum, to the normal location of the thyroid. After the complete migration, the tissue should resorb, but sometimes it doesn't, and the remnant of this tissue can cause symptoms such as cyst, sinus, or fistula. It's important to know that the tract goes through the middle third of the hyoid bone, and that's why it's very important to remove the hyoid bone as part of the procedure. Workup including neck ultrasound and thyroid function test for all thyroglossal duct cyst patient. Surgery is the treatment of choice, and it's mainly removal of the cyst with the attached tract, including the middle third of the hyoid bone, and suture ligation of the tract at the level of the foramen cecum. By doing this, you minimize the risk of recurrence. If you don't remove the middle third of the hyoid bone, the recurrence rate is very high. The procedure called cyst trunk procedure. The other differential diagnosis including dermoid cyst. The treatment is excision, and thyroid nodule should be treated as any thyroid nodule with the usual workup. Lateral neck mass, on the other hand, can be lymph node in origin, which can be inflammatory or neoplastic, primary or secondary, or vascular tumor or malformation, lymphatic malformation, lymphangiomas, or branchial cleft remnant, cyst, sinus, or fistulas, or carotid body tumors. This usually in adults, older patients. So in pediatrics, we don't see them. Enlarged lymph node, they can be neoplastic. Usually it's chronic and painless. And the neoplastic ones can be primary or secondary. The primary usually lymphoma, leukemia to a lesser extent, or post-transplant lymphoproliferative disease. Secondary neoplastic lymph node enlargement, usually metastatic, secondary to thyroid cancer, squamous cell cancer, oral cavity or nasopharynx or the skin, breast cancer and lung cancer. We see this more commonly in adults, not very common in pediatric. On the other hand, the inflammatory causes of enlarged lymph node can be bacterial, viral, atypical bacteria such as cat scratch disease, toxoplasmosis, sarcoidosis, and granulomatous disease can be caused as well, TB, and others. This is an example of lateral neck mass. As you can see, this is vascular tumor, which is newborns, which is hemangioma or infantile hemangioendothelioma. This is another aggressive form of hemangioma called Kaposiform hemangioendothelioma. This is vascular malformation. It's actually veno-venous malformation. So vascular tumor or swelling can be classified into tumors such as infantile hemangioendothelioma, which used to be called hemangiomas, or Kaposiform hemangioendothelioma, as we show in the picture. Treatment usually medical. Or vascular malformation can be low flow, such as veno-venous malformation or lymphatic malformation, or fast flow, such as arteriovenous or arterial malformation, and mixed. This is an example of lateral neck mass. As you can see in these two patients, they can be big and aggressive, or can be mild to moderate. This is a typical location of lymphangioma. They used to be called cystic hygromas. MRI is the gold standard test. As you can see, this is the large cystic structure. It can be multicystic, can be macro or microcystic. The treatment, if it's small and asymptomatic, usually observe them. Imaging required to confirm diagnosis, ultrasound and MRI. If they are symptomatic or large or causing disrupted cosmesis, then treatment of choice is injection sclerotherapy with closing agents such as OK432 or bleomycin. Surgical excision usually discouraged unless it's causing mass symptoms with airway obstruction or vital structure dysfunction. Otherwise, it's not recommended because of high morbidity and bigger scar. This is an example of a patient presented with lateral neck abnormality. It actually was a sinus. As you can see, in the anterior side of the neck, just anterior to the sternomastoid muscle. This is a typical of second branchial cleft sinus. The location is between the lower third of the sternomastoid muscle and the upper third, just anterior to the sternomastoid muscle. Branchial cleft remnants is caused by failure of complete resorption of the branchial cleft between the branchial arches. The most common is the second branchial cleft sinus or remnant between the second and the third branchial arches. The second most common is the first branchial cleft remnant, and the third most common is the third branchial cleft remnant. This is the typical location of the second branchial cleft remnant or sinuses or cyst, just anterior to the anterior border of the sternomastoid muscle, junction between the lower third and the upper two-thirds of the muscle. It has tract that goes inside between the bifurcation of the carotid artery and opens into the tonsillar fossa. The first branchial cleft remnant usually around the external auditory meatus, just below or anterior to the auditory meatus, and the internal opening into the external auditory meatus. The least common is the third branchial cleft remnant, just around the manubrium in the upper chest, and opens into the pyriform sinus in the larynx. Treatment is excision. You can do ultrasound or MRI to confirm the tract, but the treatment is excision. You have to completely excise the sinus or the tract to prevent recurrence and complication. Thank you.